how we are going to treat a patient who is having a cancer, which is oligometastatic. Okay, anyway, I'll go ahead with my presentation without waiting for this display. First of all, we have to clear up certain concepts. And one thing, we always hear, in a metastatic disease, you have a lot of drugs. Now the extent of surgery is going down significantly. And if you think about rectal cancer, especially after the discovery of dostarlimab, there is an option of not doing surgery at all. So my first question to Dr. Wesley, who is a medical oncologist. So in a metastatic cancer, colorectal cancer, can we avoid surgery? Don't be afraid. We will never attack you.
It's a yes and a no. It depends on what scenario.
I think you're not audible.
So it's a yes and a no, because you can't have a straightforward blanket answer for the whole thing. If in case I'm dealing with a situation where the patient is grossly symptomatic, has got obstructive symptoms, liver is just a single oligomet, I would probably send this patient for a surgery. Now that surgery might not be a curative intent surgery up front, but might be a palliative intent surgery. Probably the oligomet is sitting in a location which is not accessible for a surgeon. So surgery is not absolutely out of the question. The question is it going to be a curative intent surgery versus a palliative intent? So surgery being absolutely out, a no, is unlikely to happen. It is going to be there in the real world, depending on what scenario you're dealing with.
So I'm asking this question, especially in the context of so much advancements is happening in the world of medical oncology, and we have a new chemotherapy, the target therapy. Then also considering the morbidity of surgery, the impact we are giving on the patients. So will a era reach very soon whether at least a subset of colon cancer patients are cured without surgery?
Definitely, that's quite true. If the patient is not obstructed, patient is not perforated, patient is not bleeding heavily, patient is stable, probably a situation would arise where we might not go in for a surgery at all, because the primary would respond as well as the metastatic disease is. And you're not going to add to the survival either in terms of overall survival or PFS or DFS based on the surgical option that you're going to choose.
Okay. So now we'll go to certain definitions. So here we have to make clear certain definitions, that is the terminology of synchronous versus metachronous. I think as the youngest of the crowd, Fahad, can you tell about what is synchronous, what is metachronous?
Yeah, sir. Synchronous metastasis actually is when we consider a disease which is happening within 6 months. So the primary is considered to be synchronous metastasis. And after 6 months is usually the consensus is that we go for metachronous metastasis.
Yeah, so I don't waste much time on it. But next question is, when do you call it oligometastasis?
Sir, as per the usual guidelines, it is 5 sites of metastasis is supposed to be oligometastatic disease. And some definitions also say that it should be in 3 organ systems. So maximum 5 sites of metastasis is considered oligometastatic disease.
So you mean to say that the 3 organ systems are affected? Some patient having lung mets, liver mets, and colorectal mets.
Yes.
Sorry, liver is still oligometastasis.
Yes.
All the panelists agree with that? I think Saklani sir is laughing. Yes, Ramakrishnan is going to disagree.
No, I don't think there's any standard definition for oligometastasis in colorectal cancer or GI cancers. So I think I also came across a definition, not more than 3 lesions, not more than 5 lesions, and not more than 3 sites. So I'm not sure there is a definite consensus regarding that.
But he's authoritatively saying, sir.
Sir, there is no definite consensus. This is actually the consensual guidelines.
This is Fahad guidelines.
And one more thing, not all organs, I don't know whether it will come under oligometastatic. So they specifically say preferably visceral organs like liver and lung, maximum peritoneum and lymph nodes. And suppose if there is brain mets and all, or extensive omental and peritoneal disease, whether it will come under oligometastatic.
I think somebody has to think over and write an article about that.
Would not treatability of the primary be an important component of this definition? And then potential curability of these lesions also should ideally be included when you call something oligometastasis, because if you are classifying them as separate, the potential outcome has to be separate. So curability of these lesions when treated well, some percentage, and then treatability of the primary also. Primary also should be, so it's not just metastasis alone.
I think it's a surgical mindset. If you want to operate, you will call it oligometastatic.
True, sir. Good.
So you don't have non-oligometastasis at all.
So we'll move on to our overseas faculty, Dr. Faiz. And sir, can you tell what is the outcome of colorectal cancer surgery? If it is non-metastatic, what is the 5-year survival is expected? The moment it is going to liver, how much it is dropped down? Do you have any idea, any studies?
So, I mean, I think broadly speaking, if you've got, if you traditionally Dukes A, B, C, Dukes A cancer, 90% 5-year survival. But I mean, in real terms, if you looked at all comers with colorectal cancer without metastatic disease, probably 50 to 60% 5-year survival in the UK, may be different in India. When you have metastatic disease, then that survival drops. But again, a lot of the data that we refer to is old data. So for liver mets, lung mets, even peritoneal mets, all three combined, and nobody's quite sure. It's very difficult to quote to a patient in the clinic, yeah, you're going to live this long with these. So you can keep people alive until their next metastasis. Then you can take a little bit more, then a little bit more, and you cherry pick. And you may be able to keep some of these patients alive for many years. I'm sure all of us in this room have anecdotal reports of people who we thought would be dead in 12 months, who, 5 years later are still alive. So I saw a lady just last month. She had 10 liver metastases 10 years ago. She had 3 liver resections. She came to me with isolated peritoneal disease, and we operated on her. And she's someone who should have, if you looked at the textbooks, she wouldn't be alive now.
Yes, of course. And if you look at the organs which is metastasizing, I think the liver comes very first with almost, some autopsy studies have shown that up to 50% of liver is showing some metastatic lesions in most, even in early colorectal cancers. But unfortunately only, 25% of them, unfortunately only 25% will have a liver metastasis at the presentation. But as time goes on, many patients will recover. So among the 25% of patients with liver metastasis, again only 25% are curable. So we'll go to the discussion further. And resectable can be classified into 3. Yeah, it is coming. Audio, video, complete failure. Resectable or unresectable or borderline. So we are going ahead with discussing, and first we take the resectable group. So patient present with a resectable, and that can again be subdivided into a scenario in which we have the first scenario, we have only one metastasis, where every surgeon will be tempted to go ahead and do surgery. And second scenario is all operable multiple metastasis. So my question to Dr. Ramakrishnan again, when you have a patient with a liver metastasis, so would you think that considering perioperative systemic treatment will improve the outcome of the patient?
Randomized trial has definitely said it will improve the outcomes in the synchronous setting at least. In a metachronous setting, I think surgery alone should be sufficient in case of a single site metastasis.
Yeah, look straight, Ramakrishnan, don't need to look at me. Okay. And yeah, so I should have stand in the front. Okay, agreed. So I think there is an advantage for some systemic treatment. All the surgeon, would you agree that in all operable cases, except it is a single lesion, superficial lesion, needs a perioperative systemic treatment?
I think the data is there. It improves progression-free survival by 7.5 or 8%, but overall survival, it doesn't make any difference. So you have a chat with the patient. So if you have a single liver met and you've got a near obstructing lesion, 1 or even 2, you could do that as well. But probably you need to improve staging. Now we know if you have a liver met, you may either do a PET or an MRI liver. And that is where you may go wrong. When instead of having a single liver lesions, you may have more liver lesions and things like that.
Okay. And I think one worrying thing, especially Subhash should be worried about giving chemotherapy for a patient, and that will damage the liver.
especially patient having liver metastasis when you have a chemotherapy, then it may damage the liver. Any advice on how to avoid damage to liver? Dr. Wesley?
I agree with Dr. Saklani. It is good to go ahead and do the surgery, but I would probably diverge a little bit. If you do the surgery and take away the whole thing, we do know it is a metastatic setting. If we do the chemotherapy up front, even if it's for a short while, you would be able to understand the biology of the disease. So that is something that will be probably more useful in the days ahead, where the surgery, further surgeries would not be possible. The concept of chemo-induced steatohepatitis, or things that will make things messy for you to operate, if you have a limited understanding, if you have an understanding that you would be giving only a limited amount of chemotherapy just to understand the biology, it's not that it's not operable, it is operable. If you're just doing it for that sake, it shouldn't be a problem. If you give 4 cycles of Folfox or Capox or whatever drug you're giving, your liver is not going to have cash or blue liver or whatever that we worry about.
So in that context, Dr. Subramanian Rao, do you think that in a very early case, doing surgery alone is not going to benefit to the patient to any extent without having chemotherapy upfront or later on?
I didn't get you. What did you say?
No. The surgical, if you look at the survival, which is 40%, so how much is contributed by the surgery and how much is contributed by systemic treatment? Do you have any idea?
I would not be able to know that. Is it not?
If you have 40% survival with the surgery alone, so where do you need chemotherapy?
In a setting, I think I will take the whole.
How do you know? Only surgery has given you so
I don't know. That's why I'm asking you.
I don't know. I wish I did.
It seems ironical, isn't it? In stage 3, you give systemic chemotherapy, but in stage 4, you withhold it. I mean,
Senthil want to say something. Senthil is jumping ahead.
See, I think...
I provoked the tiger.
I think we are mixing up synchronous with metaconus.
Yeah.
The concept of whether you need to give perioperative chemotherapy or not comes only in the metaconus setting. In a synchronous setting, it's a stage 4 patient presentation. You have the primary to treat, you have the liver to treat, and you have the systemic therapy to be given. Once a patient has completed that, maybe 6 months down the lane, 1 year down the lane, 2 years down the lane, comes with a metaconus lesion. Then the question is whether you want to give chemotherapy in such a scenario or not. That is
here
questionable.
in the context of synchronous setting, what is our advice? Are you going to open surgery always?
That is the next question. Chemotherapy is needed. Chemotherapy is needed, definitely.
Yes.
Then it's about sequencing, whether you want to do the liver first or the colon first. If it's not obstructed, not bleeding, you have various options.
You forget about symptomatic patient, only asymptomatic. I'm talking in non-symptomatic patients with the liver mets. Would you like to give chemotherapy? And what's the quantum or advantage survival with the chemotherapy?
That is not a simple...
Sendra is going to answer.
That answer is not a simple one, because it depends upon whether you want to operate the primary first or the liver first, or you want to combine the surgery together, or you want to do both laparoscopically, or if you want to do, if a left-sided surgery, you want to do left-sided surgery with a stoma and then a liver resection. There's so many...
So please give your 5 answers for all scenarios.
Spoken like a surgeon. That's right. Okay, so I think we need to remember or not forget certain principles. Whether you give the treatment before or after, the outcome is going to be the same. So this has to be very clear in somebody's mind. So if you're going to be able to resect it on day 1, that means your primary plus 1 met, 2 met, whatever those numbers of mets might be, it's perfectly all right to go and resect. You're not going to do any disservice to your patient. You can do all the systemic therapy after the resection is done. But if for some reason you are not sure about resecting the liver or the primary, then it can be done as a stage procedure, which is what we do in our hospital most of the time. We do, let's say the liver, then they come back for some systemic therapy, they go back and get the primary resected. So I don't think the sequence is a major issue. It's important to deliver all the planned therapy there. The second important point that one needs to consider is that if you're going in with curative intent, then the role of any of these monoclonal antibodies is going to be very limited. In fact, there is some data from the UK. We still don't know why it happened. When you use anti-EGFR antibodies in borderline resectable colorectal cancer, the outcome is actually detrimental. We still don't know why there is a detriment. So the bottom line is, if you can resect, whatever planned chemotherapy for 6 months has to be given 3 months before, 3 months after, 2 months before, 4 months after. That is, the decision of the multidisciplinary tumor board. What's the contribution of chemotherapy if, we saw in the earlier talk that the overall survival benefit was somewhere around 4.5%. In a metastatic disease, you may push it up by another 2-3%. So that's where it ends up being. So we don't have an exact answer to what's the percentage in the metastatic, but that's where I would.
So good suggestions, and we'll stay back and answer following questions also.
Any
biological
immunotherapy?
immunotherapy?
I think we've answered that biological no. Immunotherapy only if it is somebody with an MSI high.
Okay, that completes our discussion here. We'll further forward with this is called disappearing liver metastasis. So what happens when you give chemotherapy upfront or systemic treatment upfront? It disappears. So Dr. Fahaz, can you tell about the significance of it? Is the patient cured?
Maybe. Maybe not.
So how do you know that, sir?
Well,
and what need to be done? Second question.
I guess, I think before you start treatment, we would always do an MRI. So you can't rely on CT or even PET. I think MRI, in my mind, would be the gold standard for staging the liver. So do your MRI. If they've disappeared, then you just focus on whatever disease is left behind. I'm not sure you need to do anything more about the liver. You need to keep an eye on it. But, often when these patients come off systemic treatment for a period of time, then those liver lesions will reappear. So you're not out of the woods. But in terms of, that would be my take.
So would you like to do something upfront, putting some fiducials or something to make it identifiable?
I don't know if I'm not aware of the evidence to support.
So I have heard some surgeons saying that after chemotherapy, the liver will never be cured or they only disappear. So is there a point in going back and identifying and removing them?
No, liver resections done after disappearance, 70% of them actually show cells. So there is disease. It might come back immediately or much later on. Leaving it behind is not the option, but sometimes you're constrained to do that. Resecting everything that was pre-existing is the best thing that you could do. You could do a lobectomy and for which, if you think they're really small and they're disappearing, you must really work along with your medical oncologist, resect before they disappear.
I think, Dr. Chandramohan, that's a really good one because I think the mindset is totally different. So if you have 4 liver mets, you coil them and you get them disappeared, so you'll either treat them the coiling with RFA. But imagine if you had bilobal liver mets and they got very good response to therapy. Obviously, you're not going to remove all those mets. It's like rectal cancer itself. Even if the disease is there, it may not present later on. So we have 2 different mindsets. You will say, what sir is saying absolutely right. You may resect those and 70% will have tumor in there. But then if you look at the other side, if you have bilobal liver mets and that tumor disappears completely, you would think it has got very good prognosis. You would resect either those lesions which are left in the liver and the primary, I would think. So but you would not remove all the lesions in the liver which were there before. So
that would be the approach our liver surgeons would take.
Yeah, thank you. I think.
But would data support that? Complete resection only gives you that the 30% advantage, is it not? Whether you are able to do it or not is different, but doing it.
That is the thing of potentially resectable liver thing. The idea is to get them into resectable one, and that would improve survival. I think medical oncologists
Sendil, please come rescue.
Because we could not settle, we have handed it over to.
I think, see, if upfront it was a resectable metastasis, you have given perioperative chemotherapy, there are just 2 or 3 metastases, it has disappeared.
Yeah.
If they are surface lesions, it does make sense to go in and resect the area of the tumors. If they are deep-seated lesions or multiple lesions, like Seklani said, where you are probably not going to consider surgery even in the initial setting, if it disappears with chemotherapy, surgeon is happy. He doesn't have to break his head over how he is going to remove those tumors.
Sendil?
So I think there are 3 scenarios that you can imagine where this problem can arise. No, I'm fine.
Come up, Sendil.
I'm fine. No, there's no place. So that's fine. I'm happy this way. So one is you've got 2 or 3, and then you think you're not going to be able to resect it upfront. You want some reduction. So there, the strategy that you're talking about may make a lot of sense. That means you want to put a clip or, one met might be 5 centimeters, the other is 4, the other is 1. You're worried that the 1 centimeter might actually disappear when you're doing chemotherapy, and then that gets lost. So there, the strategy that you're talking about makes a lot of sense, because we want to resect everything that we saw on the MRI on day one. And then there's the other end of the spectrum where you got 25 metastases, right? And just like what Dr. Saklani said, everything disappears, a few left behind. I am not in for going and resecting those 3 or 4 that are left behind, because it is foolish to think that resecting those 3, 4 is going to make a dent on your patient's outcome. The ones, you're neither in this end of the spectrum or this end of the spectrum. You got some 10, and then 5 of them disappeared, and the other 5, I think that's where the crux of the issue is. You need to use a lot of judgment, your ability to resect, so on and so forth. There comes in biology. So that's whether the strategy that you're talking about is really going to make a lot of difference in the outcome is something that we don't know. These two extremes, we know. Here, aggressive, get everything out. There, don't touch it. There's somewhere in between, there's a gray area where you just don't know how aggressive you need to put all your local therapies. That's where the escapism for most of us is to do RFA or SBRT or something like that and get away rather than going and resecting, which is what we do most of the time.
Non-surgical management also is a very...
Correct.
Non-surgical management at present is, by the interventional radiologist also is of very high, giving good results. Okay. So I think combination, even in theatre, if I take such a type of patient, I will resect 4, then leave the interventional radiologist inside the theatre to do RFA to rest of the 3. And primarily MRI, as sir told, MRI is the main thing, because if you have micrometastasis, that can only be seen by MRI. PET and triple PET CT will not show them. So MRI is the minimum. Then after that, you post chemo, you can see in MRI the scarring very nicely. If you see very carefully the MRI, you can see the parenchymal scarring, and you can assess that this part is to be removed. If it is in a resectable area, go ahead and resect. Unresectable places, leave it to your IR to decide to do RFA, microwave ablation, whatever he decides, and ask him to come inside the theatre, complete the procedure. But at present, we don't leave as such without treating.
Okay, agreed. Perfectly agreed. I think will come.
The scenario is actually that we are discussing here is about the oligometastatic disease. It's not about the broad metastatic disease.
Okay, yeah.
So when we discuss about oligometastatic disease, so we clearly know that if you completely resect it or you ablate it, there is a clear survival advantage. That is why we are taking up this oligometastatic disease. So if there is in liver, there is an oligometastatic disease, and if there is a disappearing liver mets that is identified by CT, definitely you have to better to go in and take out all the lesions or do some kind of an ablation therapy. Even with MRI, maybe they are saying up to 70 to 80% of the lesion, they have really disappeared pathologically also. But by CT wise, we have seen only up to 20% shows clear pathological response.
Okay.
But 80% of the lesion when you operate still shows lesions. So it is better to take it out either by resection or by ablation in an oligometastatic
Dr. Wesley?
Right, so putting this together, if it's an oligometastasis, obviously you're going to go in and do your surgery, and that leaves us with a small window of opportunity of not keeping this patient on a long term. You just heard about the maintenance therapy and the use of anti-EGFR being detrimental in those scenarios. So that gives us that confidence that, okay, it has been taken out, probably we can just stop it and probably treat this entire thing like an adjuvant setting and then wait on it. And the recent ctDNA data that we have heard, we have got a pretty good tool if in case it becomes accessible to our patients to keep a watch on them and make out when they are going to fail. And if you look at the bespoke trial, the bespoke observational study, at the end of it, they have talked about oligometastasis which are picked up right in the beginning with the help of ctDNA, which can be dealt with at a later point.
Okay.
So probably we are somewhere in between, and like Senthil said, the gray zone is always going to trouble us.
Regarding bilobar extensive disease, I've seen Dr. Torricelli. He does one-stage hepatectomy. That is, he decides based on, he restates with an MRI liver, with a liver-specific contrast. And he chases all the lesions, 25, 30, he chases all the changes. He uses MRI-specific contrast and intraoperative ultrasound. So that's what they do. They basically categorize into 2 lesions which are principal, within 3 centimeter of the main hepatic veins or the main porta and the peripheral lesions. So what matters is the principal lesions. If they take a lot of FLR, then that's a difficult situation. Otherwise, if there is FLR, every lesion is chased with IUS contrast and MRI with liver contrast. They are doing it, I don't know the exact numbers, but with good results.
Message well taken. We are halfway through. We have to finish a lot of things. Good. I think the thing so far is, I thought somebody will tell about this risk scoring and say, okay, the high-risk patients should go for a systemic treatment, but nobody said that. But the discussion so far says that, when a patient comes with multiple metastasis, even if it is oligo 3-4 metastasis, there is always a role for a perioperatic systemic treatment, and there is no much importance for fancy molecules. You give it and then you operate, and now you do an imaging, reasonable imaging, and remaining lesions you easily accessible to remove it. If it is not seen or deeply located, you try to do RF or something. Okay, consensus clear. So we go to the next aspect, which is very important. Is
Dr. Chandramohan, can I make
yes,
one
sir.
point?
Yes,
Since you spoke
yes.
about fancy molecules, I just want to make a point regarding
You're offended,
fancy
sir.
molecules. I'm not offended. Fancy molecules can be useful when, let's say, you've got a 10 centimeter met on one side, and then there is a 3 centimeter met on the opposite side, and then you want to get rid of both at some point in time. Our good old K-Fox, Folfox will not get you there. So you may need to use the fancy molecules there in order to shrink. And then operate, you may not need to continue it post-surgery. That's a different issue.
So when do you use it, sir? When you use, because that is a question
when
I
you
like to
want
ask
to
you
do
later.
conversion therapy.
Yeah.
That's right.
Conversion.
So when you want to convert. Yes.
So is the role of this fancy molecule, which one are you saying about?
So predominantly better responses are given by the anti-EGFR.
Okay.
So when I spoke about detriment, it was about operable ones.
Okay.
So that's the primrose.
Yeah, this also I want to bring later. Now there is a definite role for cetuximab in advanced disease for conversion. Any role for bevacizumab?
So again, I'm sorry, Wesley, you may so the incremental responses that you get when you use bevacizumab over on top of chemotherapy is not very significant. So it increases responses by about 5%, max 10%. But if you're able to choose your patients well for bevacizumab therapy, now there's evidence that if it's a right-sided cancer, then you might want to use a triplet plus bevacizumab. So that's what will give you the best responses there. Now, bevacizumab and complications with surgery is a totally different story altogether, but bevacizumab is not out of the competition completely, but you may want to use it very selectively.
Immunotherapy?
Immunotherapy comes by itself, right? Now what we do is dual immunotherapy if you have somebody with an oligometastatic disease who needs. So that's one place where you may not need this discussion in 5 years' time. It'll be only Wesley sitting there and talking about it.
Does cetuximab produce more rapid responses?
Yes, it does produce more rapid responses, both rapid and deep. So that's why it is used when you want
to. But for wild, it's wild type, left-sided.
You need to choose. That's why I said when you choose them properly.
How do you choose, Dr.
Deep means deep lesions respond.
Yeah, 5 centimeter becoming 1 centimeter is deep.
Basically, how do you choose? Question to you for cetuximab.
You have a RAS wild type.
Side, any sideness?
Left side.
Great. Okay. So Subhash, answer all these questions in very fast. You are a liver surgeon. Now Wesley has bombarded a patient with chemotherapy and sent to you. And how are you going to do a safe surgery and send patient home?
Regarding the FLR,
would you want Wesley not to give more than certain cycles of chemotherapy? Any warning?
Actually, we have the ego-slim criteria for how to go around with synchronous liver mets, actually. So, sir, what we practically adopt is if there is a synchronous liver met. So, not about this thing, synchronous liver met. If the primary is completely asymptomatic and the liver is operable, so we go ahead with a synchronous resection if it is a minor resection. So we do both the surgeries, the primary, the colon or the rectum and the liver. If it is a minor resection, there will be a lab LAR plus metastaectomy that can be done in the second sitting and send the patient for post-operative chemotherapy. So if the liver is inoperable, suppose if the liver is inoperable or a borderline thing, then comes the question of conversion treatment. Suppose if the liver is a bulky disease, it requires a major resection, then and the primary is completely asymptomatic, then there comes the role of all these scoring and all. If it is a bad risk patient, we always send the patient for perioperative chemotherapy. So that also perioperative chemotherapy where we advise only 3 to 4 cycles of chemo. So after 3 to 4 cycles of chemo, we take back the patient. If the liver is a bulky disease, then we do liver first, then rest of the chemo and the primary. Or else we do the primary resection. So that is how the primary side, that is how we sequence the disease, if it is a synchronous thing. Okay. So it all depends upon how much is the liver and what is the risk scoring of the patient. And putting it all together, we synchronize it in a manner.
Yeah, on sub-question, Wesley, you mentioned about the biological selection of tumors which is responding. So how long it will take for the chemotherapy to affect and make the tumor reduce in size and disappear? So when do you have the first CT scan and MRI after starting chemotherapy?
Generally the 3rd month.
Okay, so you give how many cycles before that?
4 cycles.
4 cycles. Okay, agreed.
Yeah, that is as sir said.
Any disagreement, Dr. Saklani?
No, I think 4 to 6 cycles is okay. Only thing if you're doing
6 cycles is too much, sir.
The 3 months. No, it depends what you're giving, Folfox or K-Pox sort of thing. The only thing if you're doing synchronous resection, you always have to do the liver first because there'll be porta clamping involved. So if you've done the colonic surgery first, there'll be venous congestion and it may affect your anastomy. So that is only for surgeons in the crowd. So always do the liver first. A lot of you will be doing lap liver resections, will be doing porta clamping. So always liver first and then followed by this.
Sir, liver first doesn't mean that what I learned in classical papers, liver first you do liver, then give systemic treatment and then do colonic cancers. Is it you're mentioning?
For synchronous resection.
Okay, synchronous, yeah. So what do you mean by other livers first? Where will you do liver first and then give chemotherapy?
So that for the liver cell. That is a
Yeah,
potential
please,
resection.
Subhash.
So suppose the synchronous setting, suppose the primary is completely asymptomatic and the liver is a bulky disease. So we know that if we send the patient for chemotherapy, what happens is liver is already a bulky disease, you give chemo to that liver and the patient end up having some kind of steatohepatitis. So operating on that liver is going to be highly morbid and very difficult. So in such situation, I would prefer to go in and do the liver first, then the perioperative chemo and the primary. Probably that will be the situation where I will be choosing the liver first.
So how do you assess, especially post-chemo liver, how do you assess whether the patient will withstand the liver function post-operatively?
It is difficult, as you said.
Some rough guideline for take-home?
Yeah, it is there. FLR is the best thing. So where you can do the CT volumetry and assess the future liver remnant. So the general guidelines answering to this question also, it is something like if it is a normal liver, more than 20% FLR is sufficient. That is by textbook. But we extend it up to 30%. If more than 30% is there, then we go ahead with the resection. If there is steatohepatitis, we make it 40%. At least 40% FLR is, if it is not there, then we won't do the resection. And if the patient has got cirrhosis, at least a child age cirrhosis, then in such cases, up to 50%. So 50% of FLR is required for going ahead with the resection.
Great.
So the CT volumetry is one method and it will give only the information regarding the volume. And how good is that liver? It is very difficult. Functionally, how good is the liver? It is very difficult to assess. The classical criteria that the Eastern countries follow is the ICGR-15. Indocyanine green retention test at 15 seconds, that is what they say, but we don't do it routinely. So that is why the planning resection is going to be difficult, and that is why in bulky disease we plan it as something like a liver first technique.
Great.
So even if adequate FLR is there, that patient might not do good because of steatohepatitis.
Yeah. Next question, will you prefer anatomical or non-anatomical resection?
So now it is mostly non-anatomical resection, especially for metastasis. So we have to keep maximum liver possible.
I think Dr. Saklani is upset. I think he's a bit sleepy, that's all. Okay, anybody upset here? Fahis, are you upset? These guys are doing only non-anatomical. Anybody, Rudra? Madhu upset?
The liver first, in addition to technical aspects, I think there is a lot of data coming in terms of the immunological effects of doing the liver first. I think over the last couple of years, there has been so much of data supporting in a synchronous, when you want to do stage resection, do the liver first because of the immunological benefits associated with taking out the liver first, because in such a patient, it's the liver that is going to determine the outcome of the patient. So take it out first and then tackle the primary later on. If you want to do stage resection.
And coming to the margin in two scenarios, in chemo-naive and post-chemo. So how do you look for margin? Because you're doing non-endemical, you have to have margin. Subhash, what is the recommended margin? Any comment, Subhash?
I think, yeah.
One cell.
The margin negative section that itself is we do frozen in post-chemo.
Even if you say that in actual reality, on a person who is passed out MCH doing a liver resection, how is going to have a margin negative?
So always, yeah.
Is it 1 centimeter?
Yeah, at least 1 to 2 centimeter around we take if adequate FLR is there.
Okay.
There are some situations where the lesion is very close to the vein or very close to big vessels, or if you have compromise on FLR. In such situation, there only the concept of margin comes. Or otherwise, we always take 1 to 2 centimeter margin all around the liver nut.
Suppose if you give chemotherapy and shrunken a liver size mass from 5 to 3. So what will the margin you're taking? It's a 5 centimeter margin. You imagine a 5 centimeter lesion or take margin for 3 centimeter only?
It is actually difficult. We don't know the original size of the lesion at that time. So sometimes there will be some features of the previous lesion that will be there, some hypoechoic area, something will be seen in intraoperative ultrasound. Then we take that area as well. Or in other situations, then we
there is a compromise. Would you agree, Ramakrishnan?
And then, of course, there is something to.
I don't think there's any compromise.
Like
See, you have to understand how the tumor shrinks.
You won't imagine as a 5 centimeter. I am not thinking of compromise in quality.
No.
I am saying compromise in margin
the tumor
size.
shrinks centripetally. That doesn't mean a 5 centimeter tumor, if it becomes 3 centimeters, the outer 2 centimeters still had the original tumor. No, that is not how the tumor shrinks.
Okay, yeah. It may or may not have.
Yeah, you give margins to what you see.
Okay.
That is where the ultrasound comes into play. You don't have to give margins for the original 5 centimeter tumor. I mean, that beats the whole purpose of conserving as much liver as possible. Especially in multi.
But you have to be really careful in removing tumor and suspicious areas, ultrasound.
I think the concept of margins is overemphasized. You just need a negative margin. A 1 millimeter margin or no margin on the ink surface is good enough for a liver metastasis.
Okay, thank you.
And we can always supplement it with frozen section if any doubt. So, and you can go in for re-resections.
You can even accept an R1 vascular margin, especially when it is close to the major vessels.
Agreed. Yeah, I think the consensus so far, we have to have a chemotherapy first and carefully look for FLR by CT volumetry. And if possible, you have to do liver first because immunological advantage. And postoperative liver function has to be really seriously concerned. And as far as possible, non-endemical. And margin should be de novo margin, not the actual margin. Aim for 1 centimeter and even a cell margin is okay. Sendil, are you happy? So coming to the other techniques, like the new techniques, port vein embolization, hepatic artery embolization, ALPS procedure. Anybody want to comment? Dr. Fahas, would you comment about these procedures? Would you do in UK?
Yeah, portal vein embolization. We do ALPS procedure. I know in Basingstoke it's not something that's done commonly. Leeds probably has more experience with that. Hepatic artery chemoembolization, again, it's not something we do often, but portal vein embolization, yes. Yeah, definitely.
Agreed. Anybody, Subhash, would you use these ancillary procedures also for?
Yeah, definitely. Portal vein embolization we use a lot because in some lesions where you don't have adequate FLR, we had very good results with portal vein embolization. The opposite lobe hypertrophies after 2 to 3 weeks, and we can go ahead with a major liver resection like a right hepatectomy or left hepatectomy. ALPS procedure, the morbidity of the surgery is a bit high, so we are not.
So what is ALPS for the benefit of postsurgeons?
ALPS is associating liver partition with portal vein ligation for staged hepatectomy.
How do you do that?
That is ALPS.
How do you do that?
So what we do is you go inside, do a hepatectomy, that is the liver transection, then you ligate the portal vein of the affected area. So suppose if there is a right-sided big lesion, so you transect the liver, then ligate the right portal vein, then come out. So what we usually do is this transection area, next time when you go in, that area will be very difficult to identify and there will be a lot of adhesion. So we wrap that liver with something like a plastic thing. So we use something like IO-band kind of things will be used to separate that area. So then you wait for 2 to 3 weeks, at least 3 weeks, then go inside again and do the resection part. By that time, the remaining liver, the FLR might have ground to a bigger size, then you can take out and complete the procedure.
Okay, great.
Yeah.
So, Dr. Subbu sir, suppose if you have a operated on a patient and you are dealing with primary and there is a metastasis on left lobe, so would you, you are not planning the simultaneous resection, would you ligate the portal vein on the same side and come out, and have you invented such things in your practice?
I've never done that, but if I think the eventual FLR is going to be low, I would definitely do that, yes.
Okay, and the other RFA etc. discussed. Now, yesterday Dr. Haridas sir was asking Subramanian Rao sir the role of liver transplantation in metastatic colorectal cancer. Anybody tried that? Anybody agreeing that? Any future? DMH is going to do some trials on it?
Though I'm not a surgeon,
Yeah.
there's a TransMed study in ASCO this year,
Yes.
which has shown that there is a benefit for a very selective set of patients.
Okay.
That's correct. So, but 37 patients in each arm, very laborious treatment, repeated resections. I'm not sure it is applicable and possible in the setup that, at least in the setup that we are in, it's not possible. But the data is there. The first time that there's been some data.
Probably the small numbers, but the survival that showed is that 5 years survival, 60%
Absolutely. Liver transplant for.
metastatic colorectal cancer.
Okay. So Subramanian Rao sir, a millionaire in Andhra Pradesh comes to you and asks you to do transplant into American. Will you do it?
I'll ask for the donor first. I for one would not waste a donor, at least in this country, because we are struggling for livers. He would be struggling for livers. I would use these livers much more judiciously.
I think the criteria for transplantation is very intense. There should be no progression on 1 year of chemotherapy. So looking at that, less than 3 to 5% would be eligible. So I think we have published a paper on that.
Okay, thank you. And we'll go to other topics like paratic nodes. So other than liver metastasis, you're having a paratic node metastasis, single station or even 2 stations. Will you consider surgery, Ramakrishnan? Let it be metachronous setting. Patient comes back with a paratic node.
In a metachronous setting, no.
Both synchronous?
Synchronous, probably after a course of neoadjuvant treatment, if the primary is resectable, when I'm planning surgery for the primary, it is just an extension of the surgery to go and remove the para-aortic nodes.
So
although I'm not sure how much it is going to add.
No, I think it should be other way around. When you see synchronous, it means it's a bad biology. When you metachronous, you have isolated only one mets developing in an entire paratic area. I think we have to remove it.
That is one way of looking at it, but I am looking at it the other way.
So how the others are looking at it, Saklani sir?
About 3 years back, Senthil's patient, we looked at it the other way actually. Because patient was actually node negative, treated completely by surgery and chemotherapy, anti-resection was done, and he relapsed in the para-aortic. Para-aortic means exactly left side of the aorta. Nodal mass about 5 centimeters in size. We did imaging, and it looked operable, so we operated. Now it's 2 years, 3 months. He's doing really well. So this is one of those single site deposit. This is the true oligometastasis. The regional metastasis, all right, but true oligometastasis, single one, so we resected because young fit patient, but the challenge here was to keep the vascularity of the left colon. The left colic was preserved, so that had to be kept intact. So that was the challenge. Otherwise, the tumor came out much more easily than most other lymph nodes of other diseases.
Chandra, when you're talking about this metachronous, don't you think that the time interval between that the disease free, that is what matters? So if it is going to be immediate, then what Rama says is the tumor biology and other things. If it's going to be a long time interval, then it definitely gives something good results for the patient. That is what should be the carryover. The time interval is what matters.
Dr. Chandramohan, there are 2 good series, both from Japan and Korea. There are about 25 and 40 patients who looked at isolated para-aortic node, and their survival looked like 5 years survival of 40%. We operated about 50 patients with para-aortic nodes, and the outcomes were not very good. 6 months, they all came back with disease. So in fact, we changed the plan that if you have para-aortic node, which is not single or something, then we give radiotherapy to these para-aortic nodes. And if the response is really very good, then you will operate the primary. And if there is a residual nodes with there. So I think we did a thing, and outcomes were not good because all of them had disease recurrence within 6 months. But there are series from Korea and Japan where the 5-year survival is 40%. Synchronous. I'm talking about synchronous. Metachronous, I think if it is only an isolated site, it's not much to do. Yeah. I think we have done one who's still alive after 10 years.
Subhash.
Yes, in metachronous settings, whenever we say about metachronous, so there are many guidelines which differentiate an early metachronous and a late metachronous.
That Dr. Ayyappan had mentioned.
Yeah,
Anything else?
After 1 year, if it is a good risk patient, why can't we operate?
Yeah, I think we have to operate. Only Ramakrishna is opposing it.
Do you have any evidence that operating and removing that leads to long-term survival? I don't think so.
No.
Yeah.
We'll still be open.
I feel giving radiation, if it is amenable to radiation, systemic therapy, because even if it is an isolated para-aortic nodal disease, there's very high chance that he might have systemic disease. So you give it a test of time. After radiation, see how the response is.
Your philosophy can be applied to anything. Even with the localized, you'll have ctDNA positive.
I'm not going into ctDNA positive.
Even with a single metastasis, ctDNA goes up 90%.
So let me ask you, if you have a para-aortic node, a resectable para-aortic node, synchronous lesion, operable primary tumor, are you going to say that you are not going to resect that? You will still resect that, isn't it? Yeah. So that's what I'm saying. Synchronous, definitely I will go in and resect if it is resectable. Because, what other chance does the patient have in that disease?
But is there a survival advantage in para-aortic?
I don't know. That's what I said. I don't know. But I cannot leave the patient. But I cannot leave the patient without surgery in a synchronous primary, resectable primary.
Okay, we'll go ahead. So I will come to the...
Yeah, correct. Doing, yes. True.
Large segmental resection or a significant liver, then we'll stage, and we get the liver surgeons to do the liver first, restage. Ideally, in our experience, when we've gone in too soon or done things synchronously in that situation, the incidence of recurrent liver metastasis is quite high, plus the complication rate, post-operative morbidity is very high. So if we've got operable liver metastasis, do the liver first, leave it some time, 2 or 3 months. Our liver surgeons push us and say, no, you've got to go in, and you've got to go in a few weeks and do the peritoneal disease. We'll say, no, we'll wait, restage 3 months, another MRI. If the liver's clear and there's no new sites of disease, then we'll deal with the peritoneum as a staged procedure. But we've got our fingers burnt when we've gone in too soon. We've had widespread peritoneal progression or new liver mets. So I think you need to be careful in that situation. If someone has a lung met, then I think if the lung met is ablatable, then we'll go do that. If they require a VATS procedure, then fine. The problem in the UK is all these things are discussed in different MDTs. So there's a lung MDT for a region, there's a liver MDT, there's a peritoneal MDT. And so those tumor boards don't always talk to each other, and then they play tennis. No, we'll do the liver first if you do the peritoneum. No, we won't do the peritoneum unless you do the lung. And then nobody makes a decision. And then 2 months later, the patient's no further forward. So someone just has to take ownership and say, okay, this is how we're going to do things. But you need to promise that if we do this, you're going to do that, and don't back out. But it's an issue in the UK anyway in terms of decision making, because nobody really knows, and there are no definitions for oligometastatic disease, or even for synchronous metachronous. You'll see lots of different definitions: 3 months, 6 months, 1 year, and the people are just playing past the parcel. So someone needs to take ownership of the patient and make the decision.
So I'll tell you another scenario. We are opening up abdomen for a colectomy, and there is limited peritoneal metastasis.
Yeah.
Of course, there is a consenting process involved. Suppose you had consent to the patient, will you go ahead with the HIPEC as well in the primary setting?
So you've got to have HIPEC ready. Not everyone has access to get the HIPEC there and then. Most places, I think, most surgeons would probably just resect that disease. And I think if you look at the evidence, the benefit of adding HIPEC when you've got limited peritoneal disease is questionable. As long as you clear that disease, then, how much is the HIPEC going to add? Probably not a huge amount. Those patients are probably going to need systemic treatment if they haven't had it already. But resecting it in its entirety is probably, it would be adequate.
What he wants to know is, HIPEC, you would need a consent when the patient is awake. That's what he is.
Yeah, I mean...
in UK.
Yeah, in the UK, you wouldn't...
Here too.
Yeah, you would have to consent.
Here we take consent after
Everywhere.
surgery.
No,
you couldn't just
Chandra,
pour the
don't monk at that. Chandra, we also take a consent here.
Yes,
see,
but the patient will give consent.
Yeah,
usually.
what I wanted to say in this thing is, just adding on to what Chandru told, any GI malignancy never open up without a diagnostic lab. You made that statement. I thought it should, because
so I'll remodify my question. On diagnosed laparoscopy, there is peritonitis.
Yeah.
What will you do?
Then the whole thing is depending on the PCI, you take a call. If the PCI is going to be less than 7 and then other things, you feel that you will be able to go.
Would you like to call in any other factors like signet ring type, pathology, anything?
Yeah, that's all. The pathology is all behind. So we keep those things in account and then we proceed accordingly. If the PCI is operable, everything is fine, go ahead.
And the other thing, just to make a point to the residents, is in women, always talk to women about the ovaries and fallopian tubes. Because the number of patients who come to us with Krukenberg tumors, when there was an opportunity, particularly in postmenopausal women, where you could have taken the ovaries out at the same time, and this is even in primary tumors that have not metastasized, as a standard of care in Basingstoke, we will always say, we're going to take your ovaries and fallopian tubes out. In premenopausal women, you have to have a more involved discussion about fertility preservation and about what the risks involved are. But if you can take the ovaries and the appendix, because there is a small incidence of synchronous appendix tumors, probably about 5%. So you have a colorectal primary, talk to the patient about appendicectomy, prophylactic, but also in women, talk to them about the ovaries and fallopian tubes. Because otherwise you'll miss an opportunity. And I think we're seeing a lot of patients with Krukenberg tumors and they're very symptomatic when it could be avoided.
So for Dr. Fahis, I think Ramakrishna is going to ask what is evidence?
No. I think the HIPEC T4
not
given enough evidence that HIPEC T4 also included cytoreduction. It included removal of the ovaries in women. It included omentectomy, removal of the round ligament. So that gives evidence and there is, I think, a study from India which has shown around 17% of normal-looking ovaries did have metastasis.
Okay. So it's a take-home message.
So Dr. Chandramohan, the only thing is,
good
these
message.
are high-risk tumors which we know. T4 tumors, N2, signet ring, they have a high propensity of peritoneal metastasis. These patients are consented for additional procedures on table. Because
HIPEC. And removal of ovaries.
We won't have any chance to go back in again because the list is quite full. So.
Great, sir. I think we'll go to the yes, sir.
Whenever this N2 business comes, and high-risk cases, always evaluate it thoroughly, get a PET, because many a time we get the supraclavicular nodes.
PET scan.
That's what, we have seen many of them with supraclavicular nodes. We need to be a bit careful because we do extensive procedures. Within 2-3 months, when you come for examination or follow-up, you'll have huge nodes there. Be careful about that.
I think then we have to move to the further other organ metastasis. For example, if you for the definition's sake, if you have a single bone metastasis, it's also oligometastasis. So are you going to curatively manage the patient, Dr. Saklani?
I think if you have bone metastasis, first you think there are many lesions in the bone. They may not be lytic at all. There may be something else. You can do a PET and see like that. But I think bone metastasis, even if it is oligometastasis.
So PET is negative. PET is taking only one side.
I won't do any curative option for this. We will have palliative treatment.
You won't radiate. Madhu want to radiate.
Radiate, but no curative option for the primary.
Any difference of opinion?
I think as far as bone is concerned, the most important thing is whether it's a weight-bearing bone or not. What is the risk for pathological fracture?
Fine.
If it satisfies all the criteria.
It's symptomatic management, not for cure.
No, it need not be only symptomatic management. If it is an isolated site of bone metastasis, I think it is as good as any isolated site of liver metastasis too. So you can resect the bone metastasis, or if it is going to be a very difficult resection, like in pelvic bones, you can plan for radiation.
Yeah. I think the way ahead, I think very soon the Senthil is going to replace all of us with this team with the magic bullets, magic pills for all these cancers. And I hope that that happens after our retirement. The tumor biology, reducing, avoiding surgery. Dr. Wesley, would you like to take on this issue? Is it going to?
I think I'm going to change my profession to immunosurgeon. So it will be laparoscopic, robotic, HIPEC, and immunosurgery.
Okay, I think we have a few more minutes left. Any take-home messages? Otherwise, Fahad, can you tell?
No, for oligometastasis, Chandramohan.
Yes, sir.
would you look at mutations before you start doing anything actually?
I would definitely prefer to. Yeah, there's no doubt. I definitely want to.
In the workup, I think.
In the workup from the tumor tissue and whenever the ctDNA comes around.
So, taking that further, in a BRAF mutated liver metastasis, would you plan for metastarectomy? You know the prognosis is very bad.
So it's not number alone, it is.
It's not the number of take it out, having it there is yes.
Would you refer the patient for a metastarectomy?
Yes.
BRAF mutated too?
Yes, as of now.
As of now.
So Chandramohan, I think oligometastasis must look at surgically bad disease and biologically bad disease also. Is it not?
So if you have surgically not so bad disease, biologically bad, will you refuse to operate liver?
If it's
No.
operable, it should be
We should continue to operate.
That's the only curative option that you might have for this patient, which will at least give a PFS.
What is said is, if it's biologically bad, you do non-surgical therapy first.
Yes, sir. Good.
As a preference, and then
So
operate.
anything that is going to be morbid, you will certainly avoid. Anything that is going to be part of your, you're just resecting a small area, and I mean, when all you guys think
it's
that it's
difficult
not
to
going to
predict,
be
sir.
very morbid for the patient,
Yeah,
it's okay to
sometimes
do it.
complications can develop with the.
That's okay. That can happen with any BRAF directed therapy also, for that matter.
Quality of life is just maintained.
True. Sendil sir is very excited.
Add all these things to be spoken to the patient and that.
True, sir.
All these things. That the biology of the tumor is the most important thing which is going to result. And then once as Rawaji was telling, talk to the patient and then give some therapy, see the real biology, and then proceed inside.
Excellent. Any take-home messages from the faculty? Otherwise, I'm done.
Leave us alone.
Thank you very much.